Thanks, Abby. I think you redefined advanced imaging and radiation therapy to meme creation with that last image. So now we're going to take questions for all the speakers in this session. We do have a few on the Zoom already, so I'm going to start with those. The first question was for Dr. Zhang. In regards to AI contouring, in your estimation, how long do we have before we reach widespread use of AI-generated contours in clinical practice?
Well, like I said, it's easier to contour a lot of OARs, most of the OARs, and I think that has been in some commercial products now. So for that part, the answer is like now or in the coming couple of years, right? But there will be challenging cases like CTV, target delineation in general, and also some difficult cases like sigmoid column, right? So that may take a bit longer, but overall it's going to be shown. That's actually a very how do I say, relatively straightforward application of AI in oncology.
That's great, thank you. I had a question too, and this could be either for you, Dr. Zhang, or for Dr. Wang. I've heard a lot of physicians and physicists complain about AI, that it's going to put us out of a job. And I liked that you, Steve, said that it empowers clinicians. So how can we start to redefine our clinical roles in the era of AI, and how would you respond to that criticism?
So, like I said in my talk, I personally don't believe AI is going to replace our physicians or other clinical staff. AI is going to help us and do part of our jobs, such as those simple ones, repetitive ones, and AI is going to provide some sort of assistance or suggestions to those challenging ones. We need to make the final decision. We need to use an AI solution as a starting point to improve it, to review it, improve it, revise it. So I personally think AI will be used in a way. Actually, there was a recent work from MIT published on archive.org a couple of weeks ago. It is a very interesting idea that is with what we have been working on. That is, AI can decide what it can do by itself, what it does not feel good to do it by itself, and it will defer to human doctors. So that is based on the some rigorous mathematics, not just like some random choice. So I think that's how AI will be used in medicine in general. And AI can decide, okay, this is something simple. I have done this many, many times, and history shows I can do it well. So I will do it maybe just quickly. Physicians can quickly review it. But this is something I'm not sure. This is good. This is a very rare case. Or this is a very difficult case. I don't feel good at all. I'm going to defer it to physicians, right? So that's how I see human-centered AI can work in healthcare. It's going to be some sort of coexisting, collaborative type of relationship. So in general, I think that's how it works. But I think physicians, physiologists, and also other clinical staff should be also prepared and first understand what AI can do and what AI cannot do, and then be prepared how your job is going to be changed, going to be shifted. It's not going to be same thing, same type of tasks forever, right? So that's how I think. Like one example is like the imaging, right? We are talking about auto contouring, auto planning, right? Apparently, a big part of the imaging's job, the easy one, the repetitive ones, will be done by computers. But what the imagist can do, my opinion is that new jobs such as adaptive therapy, right? Like ESOs, like Unities, Vueries, plans will be adapted, new plans will be generated at a much higher frequency than what now, and who is going to do that by the Linux, and who is going to do all this work, right? So I believe clinicians will play very important roles in adaptive therapy, and that's perhaps where we're going to have more workloads, but will probably reduce some work we do now, right? So I think that's something. There's no simple answer, but I think roughly that's how I view our field and also other fields moving towards.
That's great, thank you. Do we have any questions in the room for any of our speakers?
I just want to comment on first I want to echo Dr. Jiang's comments. So I think, yeah, so the job definition probably going to change when the AI is coming in. But I think like just before we use emails, there are probably a lot of jobs for the, in the USPS. But now when we have the email, we'll use more emails. There's going to be just more job on the server maintenance. So that's one side. So we need to be prepared for this transition, because I mean the technology is always moving the world forward. Second, I think particularly in medicine, there's also a liability issue. So I mean, although so that's why I think I totally agree with Dr. Jiang. So this AI right now is probably just a helping tool and provide a good or consistent starting point for different tasks. That's all I have.
Great, thanks, Joel. Questions in the room for our speakers? Yes.
So a question for Dr. Zhou. So if you think the FLASH is based on the oxygen difference between normal and the tumor tissue, any thoughts about those tissue that already are hypoxic, like the spinal cord or brain?
Then you are out of luck. If you do not have oxygen there for radiation or flash to deplete, basically it's in the same situation like tumor tissue.
Any other theories behind the FLASH besides the oxygen?
Yeah, probably I should mention the radiation-induced oxygen depletion is one of the hypotheses at this point. But it seems it's the most popular one. There are other competing hypotheses too. And I think time will tell which one is the correct one. But it looks like, I mean, at least for physicists, we probably can understand the radiation-induced oxygen depletion hypothesis much easier.
Other questions from the room? Dr. Rank?
So this was a question for Dr. Bessemer. So Abby, on the virtual contrast image you showed, and it was a kidney lesion, but there was also the vertebral body and so on. Are you still able to use your windowing tools, for example, to optimize the image? Because I didn't find the kidney lesion particularly easy to see, but I thought it might just be the way it was presented on the image. But you still have the ability to window level that, correct?
Yeah, for sure.
Okay, we've got another question from the Zoom for Dr. Jiang. So Dan says, phenomenal work, very fascinating. Her first question is, for the prostate dose prediction project, you showed how planning styles affected the original model performance on a different style. So the question is, for the dose calculation prediction projects from less to more accurate algorithms, how did the model navigate through different beam arrangements and planning techniques in the heterogeneous data set you showed?
Okay, thank you, Dan. I need to clarify, there are two types of work we do in terms of dose distribution prediction versus dose calculation. So dose prediction work is based on patient anatomy. You don't need any other information. You just look at patient's anatomy, you predict what the optimal dose distribution should look like for this patient, right? It's similar to rapid plan, for example, but rapid plan gives you the DVH curves, and here we give you three-dimensional dose distribution. So that's for dose distribution prediction. The other one is those calculations. So those calculations, it's like you already have a treatment plan. You have the Fluence maps, the sequences. Now, how the dose should look like. So this is a dose calculation. Typically, you use, models like AAA or Monte Carlo simulation or Accurates, right? But we just found out deep learning can be an alternative to those things because they can be very fast, like real time, and also accurate, like Monte Carlo dose calculation accuracy level, right? So I think your question is about those calculations because we we did have challenges to publish our work because a lot of reviewers will say, okay, you train your deep learning model to do those calculations. What if you have a situation that was not included in your training data set? Is your dose calculation model going to be broken, right? Give you ridiculous results, which is possible. So that's why when you train your model, you have to include all the possible situations in your training data set, such as the metal artifacts, for example, right? You should consider that too. So when you do that, then your model should be robust enough. However, there might be still something you cannot even imagine at the model training stage. So that's why your model should also be able to predict the uncertainties. You should be able to know what you can do and what you cannot do. Like what I was saying before, the model should say, okay, in this case, I can calculate those very accurately. But in another case, that is totally something new to me. I've never seen anything similar to that. So I don't feel good. I will tell you that, and you should be careful, right? So that's my answer to this question.
Great.
A question for
So Megan, I don't have audio. I don't know what happened. I cannot hear anything.
Dr. Rank, are you pressing your button?
definitely pressing my button.
Steve, can you hear my voice?
Yes. Now
Okay. Yeah, Dr. Rank is asking a question from the audience. I don't know why the audio is not coming through, but I'll keep my mic unmuted just in case that helps.
And let me know if you can't hear me. So let me quickly summarize. So I was talking about, I don't worry about AI making physicians obsolete. What I do worry about is workflow.
Okay.
And how that may impact workflow, just as the EMR, we would like to say, has probably made our lives harder, not easier. That being said, it's probably important to measure kind of impact of AI as it goes on, but we also have to remember some basic things. I'm old enough, I remember when we did not have a PACS system. And in fact, I got high scores in medical school, not because I was brilliant by any means, because I could find the missing file from the radiology room that had to be found that was never checked out. And so those are things that are not quantifiable. But when we're looking at impact of things like AI, it's probably going to take some really creative thinking about metrics to really say, how did it impact? And it may not be things that are just really obvious.
Are you done, Dr. Eng?
I am done.
Okay, thank you. Yeah, because I thought you got muted again, maybe. Okay, well, that is a very good question. I totally agree with you, right? what happened to EMR, to Epic, to all these EMR companies. They actually, I heard a lot of complaints from our physician colleagues about Epic and other software. So definitely that's something, a big lesson we need to learn from there, right? When we try to deploy AI in our clinical practice. And that's something we have been thinking about. We have been trying to avoid a similar type of mistake. So for example, one thing we do now, while we're trying to implement AI in our clinical practice, or even when we try to research, do research using AI to help our our profession, our field, we don't want to work solo like physicists or computer scientists trying to pretend we know everything. We know all the clinical problems. We know how to improve our clinical practice, right? I think that's totally wrong. We should not do that. We should involve our physicians and other clinical staff from the very beginning. We should work as a team. For example, at UT Southwestern, we're launching right now a campaign called the RO 2030. So the idea is how radiation oncology should look like in 10 years with the help of AI. So this is a big campaign. We look at every aspect of radiotherapy from scratch, from the first principles, like what we learned from Elon Musk, right? So our idea is radiotherapy is like what we have now, not because it's the optimal.
It's 10 o'clock.
Sorry, that's my computer. So it's not because it's the optimal way to do things. Not necessarily true. It's just because historically, it has been involved into this because of all these historical factors, limitations, or availability of technologies. And now with AI, maybe we should re-examine what is the optimal way of taking care of our patients with radiation, right? We should look at everything from scratch. So by doing that, we cannot just have a few researchers or medical physicists sitting there imagining, what's the optimal, why we should do it differently. We work together with our physician colleagues and the team, trying to examine each step of radiotherapy, also each disease site, what we should do. Imagining AI can do a lot of things for you, how radiotherapy should look like in 10 years. So we hope by doing that, we can at least avoid a big part of the mistakes that the EMR companies have made in the past.
Great, thank you.
Thank
Dr.
you.
Zen?
Yeah, thank you very much, Dr. Jiang. Very nice talk. So I would like to take a little bit different view on AI, even though I don't worry about my job. But this is more ethical question. So now with the more deep learning, with more data collection, I think AI will continue to improve. So I know physician, and I can speak for myself, represent one physician. So we have a limitation in terms of experience, knowledge, and the skills. Whereas AI represent a collective wisdom, knowledge, skill, and experience. So for instance, if we consistently show that, for instance, a mammographer, now the AI constantly outperform radiologists. It is not ethical now to use that the technology that has a better outcome than each individual physician. So I think in certain areas, like I just mentioned, the diagnostic radiology, whereas AI clearly is better. If that's the case, my question is ethically, can we continue to use what we are doing now?
Yeah, like I mentioned, there are certain areas in healthcare that you do have ground truth. I think diagnosis in most of the cases, yes, AI, you can train AI with, if you have a lot of data, you have good high quality data, maybe the model performance can be better than a lot of physicians. So in that case, do we still need physicians? Do we still need radiologists? I would say the answer to me, the answer is still yes. Because like I said, most of the time, yeah, AI can do a better job. You still need someone to sign the reports, right? Someone to be responsible for the diagnosis. So I think that would be a human doctor, not a computer. But also there will be cases where, you know, it is very rare. Also for whatever reason, it's quite challenging. And that you still need the human doctor to look at that. AI can tell you, okay, I'm not sure, you know, this is something I don't know. I don't know for sure. I need your help, right? So if you can, in that case, the human doctor can work with AI with that kind of scenarios. But overall, I think AI can help physicians, radiologists to spend to reduce a lot of time they need to spend in the dark room, and perhaps they can spend more time with patients. I naively think radiologists should really talk to patients, not just spend all their time looking at the CT scans in the dark rooms. You know, because I naively think the diagnosis should be based on a lot of factors beyond the images, right? So that's what I think.
Great, thank you so much. So we have just 1 more minute. I have one more question for Dr. Zhou in the short amount of time we have left. What do you think are the biggest challenges that's keeping Flash RT from reaching widespread clinical use? What do you think is the next step to make that happen?
Well, in my talk, I only give you a kind of bird eye view of the situation, or I picked the low-hanging fruit. And if you want to carefully consider the details of the process, it's very complicated. For example, the diffusion. Now you have to consider all those different capillaries locations and different membranes, all these things. And it's very complicated. And also, as Dr. Jiang asked the question, you know, there are still situations that normal tissues may not be well oxygenated, or tumors, they may have pretty high oxygen concentration levels inside. And probably for us, I think we need a better technology to, for example, to non-invasively to measure all the oxygen concentrations inside the patient before we can really use this widely on all the patients. The skin situation is relatively straightforward, easy, and the patient got treated and on a compassionate ground. And to go beyond it, electron is not the best choice because we all know the PDD curve. I mean, it cannot treat deep-seated tumor. People are working very hard on the proton side. I hope we will be able to have access or to hear reports from them. Because many experiments, they failed. And we don't know why, or at least we do not have access to those information to carefully analyze them. So it's still a long way to go. But if it's true, then it can revolutionize the radiotherapy treatment.
Absolutely. All right, let's thank all of our speakers from this session again.
Thank you.